Hello everyone. We'll talk about the quality improvement in healthcare system in this video. Quality improvement in healthcare. First, let us understand the definitions of quality. In fact, believe me or not, nobody is agreed upon a perfect line of quality as far as healthcare delivery is concerned. So if there is no single agreed upon definition, we move to the perspective of quality? The medical profession has traditionally dominated by definitions of quality, but there is a growing movement to include the perspective, the point of view of the patient and other stakeholders too. Patients may value different aspects of quality rather than the healthcare provider. Does the generally patient value? It's a value for money. History of quality in healthcare. Florence Nightingale is considered the pioneer of healthcare quality. Donabedian, 1966, is another pioneer of healthcare qualities. The concept of healthcare has been an issue since Florence Nightingale's time. Let me give you the definitions of healthcare quality. Donabedian in 1987 says manner in which practitioner manages the personal interaction with the patient, as in it becomes a relationship oriented. Patient's own contribution to the care, amenities of the settings where care has been provided, facilities in access to care, social distribution of access, social distribution of health improvement attributable to the cares. What did 4 years earlier Maxwell stated in 1984? It says access to the service, I'm talking about healthcare services only, relevance to the need, effectiveness, equity, social acceptability, efficiency, and economy. But of more recent times, in 1996, approximately 23 years back, or should I say 27, 28 years back, we were talking about Langley. Langley stated everything about performances, features, time, reliability, durability, uniformity, consistency, serviceability, aesthetics, personal interactions, flexibility, harmlessness, perceived quality, and usability. But of recent, within this century, if somebody has to state around here, the Institute of Medicine and Committees on Quality Healthcare in America, excuse me, stated in 2001, safety, effectiveness, patient centeredness, timeless efficiencies, and equity. Now, approaches to quality improvement may have been changing, and changing is the focus we are talking about it. Sometimes it is on the organization, sometimes it is on the professional, sometimes it is just between the interaction between the participant and the system, the doctors, the practitioners, or and the patient perhaps. Quality may be controlled and improved by self-regulations among its professionals, as the case might be, external control, regulation, and incentives, patient power, which may be exercised through the market forces, reduction variations, and waste in organizational process. Quality may be improved from top down, bottom up, or outside view, or a ringside view that can gives around it. Key figures in quality improvement. W. Edwards Deming stated emphasize management committee commitment, customer focus, and continuous improvement. Develop the PDCA, plan, do, check, act, cycle, PDCA. Joseph Juran stated focuses on the managerial aspects and reducing variation, promoted quality planning, control, and improvement. Philip Cosby advocated for zero defects and conformance to requirement, believed quality reduces cost. Armand Figobum defined quality as management style, and everybody's responsibility. It cannot be located at the top echelon or the doctors or the practitioners or just on the patient or just on the ethics. It is an everybody's responsibilities because it can be categorized as quality cost. Now, talking about quality improvements, what are the key points? Management commitment and employee awareness is absolutely crucial according to Demings. Action need planning and prioritization is what Juran stated. Teamwork is essential, is mandated by Ishikawa. Tools and techniques are necessary. The seven quality control tools. Management tools and approaches are needed, as been said by Fijabam, and customer focus is essentials, again stated by Deming thereby. Now, focus on the customer needs. I'm talking about total quality management. The customer is the patient most of the time in the healthcare system, both external and internal customer, IPD or OPDs patients are important for organizational success. Process orientation, quality is achieved by improving the process within the organization. Employee motivation, total quality management assumes that employees are naturally motivated to do good work. Data-driven approaches, statistical methods, and data collection are used to identify and probably solve problems too. Let us talk to you about the 10 principles of quality management. Number one principle is productive work is accomplished through process. So there should be a system in place. Number two is sound customer supplier relationship is absolutely necessary for sound quality management. Point number three states the main source of quality defects is the problem in the process. Again, it's a system issue. Poor quality is very, very costly. Remember, a customer who has experienced poor quality will never give return business to the same organization. Understanding the variability of processes is the key to improving quality. Quality control should focus on the most vital processes. The modern approach to quality is through grounded in scientific and statistical thinking. Total employee involvement is crucial. New organizational structures can help achieve quality improvement. Quality management employs three basic closely interrelated activities: quality planning, quality control, and quality improvement. I repeat, quality planning, quality control, and quality improvement. So if only we know then what can be done. Let's say quality improvement tools can work when we are spending too much time analyzing the process. Or teams can enter PDCA, plan, do, check, act, or plan, do, systemize, and act. A cycle of several places that goes around it. Then we can have a cross-functional teams with people borrowed it from every department, every possible department. If it is in healthcare, it can be from nephrology, cardiology, you name it, and we can have it. It can be from the management team, the administrative team, it can be from the levels of employees which we are going into it. Why are we looking into it? Because we are trying to shift the blame from individual to process. It's cross-functional team that we are able to look into it. We will be able to pinpoint where things went wrong. So balanced coast card are very improved SPC, statistical process control, is an enormous potential that goes around it. Quality improvement methods are, remember, are fun to use. They will give you pinpoint issues where things are not working in the requisite direction. So yes, involving doctors is difficult, but their point of view is required. Training needs may arise. So PDSA is plan, do, study, act model. A cyclical approach for process improvement involves planning, implementing, studying, and acting on the changes. Considered a foundational quality improvement technique. SPC, I have repeatedly stated to you, the statistical process control system. Use a statistical method to identify variation in the process. Remember, even in this variation, certain variation are acceptable within a limit, but beyond the limit, things can go wrong. So help distinguish between natural variation. As I say, certain variations are acceptable, natural variation and variation requiring correction. Control charts are used to monitor process behavior over a period of time. Lean, a methodology focused on eliminating waste, maximizing the value for customer. Originally developed in manufacturing but increasingly applied to the healthcare system, lacks a social strong outcome in the healthcare setting per se. Six Sigma, a data driven approach focused on the customer satisfaction and reducing defects, uses DMAIC or define, measure, analyze, improve, control cycle. Again, I repeat, define your problem, measure your problem, analyze your problem, improve the solution, and control it. Less commonly applied in healthcare compared to manufacturing. Now, let us talk about the clinical approaches to governance or improvement. First is the governance, or should I say, clinical administration, a system for ensuring quality in clinical care. Includes formal audit, focuses on clinical effectiveness and risk management, emphasizes both on clinical issues and organizational culture. Clinical guidelines or pathways, structured plans designed to implement clinical guidelines and protocols. Provide guidance on each stages of patient management for a specific condition, aims to improve care, continuity, and coordination. Now, what are my quality improvement tool? Number one is benchmarking. It is all about learning from experiences of others. Remember, not your experiences. By comparing what is standardized, what is actually been done in other definitely better or comparable organizations. It can be internal within a company. It can be competitive with a competitor functional. Also, we can have brainstorming as a sources as to what can be done about benchmarking, what we are going wrong. Now, there can be a checklist, as in checklist as in ticks to be marked for a checklist whether things have been accomplished or not. So list out the key features of the process, equipment to be checked. Then we can have departmental objectives or purposes, tool uses to facilitate what is required and not. FMEA, a failure mode and effect analysis, a planning tool used to build quality to a product or service in either design aspect or the process aspect. It looks at the ways in which products or services might fail and then modifies the design and process to avoid those and minimize them. Flowchart is a basis of application and of other tools, a diagrammatic representation of the steps in a process often use standardized symbol. Many variations are available. Housekeeping, essentially about cleanliness, production environment. These are the mistake proofing technique that one utilizes over a period of time. Policy deployment. What are we looking into it? We are deploying statistical methods as an acceptable mechanism to understand where there is a variation, what kind of variation is acceptable and what kind of them. Then we can talk about quality costing as in identifying the cost of every complaint that comes around it, of every issue that has been either sounded or you just might have found anything. So you are talking about PAF, Prevention Appraisal Failure, and it is being developed by Fagerbaum in 1961. Quality functional deployment, we are talking about incorporating knowledge about needs of customers at every stages and thereby designing and manufacturing the delivery process. Thereby, you need to pinpoint and it should be customer focused, customer centric. People might be sensitive, people might be carefree, but it should adapt to the mood and the requirement of the customer. Total productive maintenance can be considered the method of management combining the principles of productive maintenance with TQM. So, process view of organization is to key to successful quality improvement effort involves mapping, improving, and adhering to improve process, requiring examining interaction between elements of the organization. System thinking, a way to understand the properties of the whole system, useful for understanding medical system and their interaction. Next is emphasis, purpose, structures, unintended consequences, and cooperation. Factors affecting quality improvement. There can be variation, flows, and customer focus. Variation, understanding, and managing those variations within the process is very important. Flow, managing the patient flow through process is vital for the efficiency of the organization. Customer focus, identifying and understanding the customer need is essential. Patient involvement in quality improvement should be very, very limited. High impact changes in NHS or National Health Services. 10 specific changes designed to improve the efficiency of the NHS. Example include treating day surgery as a form as the norm and reducing unnecessary follow-ups. Now, what are the challenges? First, demystifying the process. Quality improvement should be accessible, and people should understand why a person is undergoing certain processes altogether. And I am not only talking about the patient, but also about the medical practitioner or the caregiver. Clinicians' responsibility. Clinicians should recognize their role in system-wide improvement. Management limitation. Managers cannot achieve improvement without the clinician buy-in. Without their interventions, management cannot do anything. So it is a team effort at the end of the day. With this words, I come to an end of this video. Thank you for watching this video till the end.